This meeting is being recorded.
Good afternoon. My name is Derek Mitchell. I'm the CEO of IPPOSI, the Irish platform for patient organisation, science and industry. And you're all very welcome to our digital discussion, the third of which in our series on health information. And the title of today's discussion is Involving Patients and the Public in the Digitalisation of Healthcare and Research. I'm going to give a very brief introduction to our main speaker and also to our panelists who are here from different aspects of the Irish health information system. And our main speaker today is Morten Pedersen from the Danish public health portal, that's sundhed.dk. And so the housekeeping things for all of our participants today is that there will be a panel discussion following Morten's initial 10-minute presentation, and where we will get multi-stakeholder perspectives into the discussion. And we're looking forward to hearing from everybody on our panel. And then we're opening it up for more broader Q&A with the participants. So please feel free to enter something into the Q&A box at the bottom, and we'll be moderating that. Some of our IPPOSI team are here in the background. I will just give a word of thanks to all of the IPPOSI team who've been involved in the setting up of today's and indeed the two preceding digital discussions. These discussions are being conducted in conjunction with a series of podcasts that we're also running with interviews from key people within the Irish health information sector. And I would encourage you to go onto the IPPOSI website to find out more about those. The event was made possible, and today's event was made possible through a number of unrestricted grants from IPPOSI industry members. That's Astellas Pharma, Pfizer and Vertex, and I wish to thank them for their support for these kinds of initiatives. It is our attempt, at least in IPPOSI, to replicate some of our previous conferences in terms of face-to-face. And over the next few months, we certainly hope to be testing some hybrid, more face-to-face and blended events. So watch out for those coming through in the next months as the restrictions and people get used to this new way of working and interacting. So without further ado, I will probably hand over to Morten Pedersen, and Morten is going to set the scene in terms of lessons that we can learn from the Danish public health portal. And very much the topic of patient or citizen portals is very much, I guess, a starting point for today's discussion. It's something that in IPPOSI we've been particularly interested in, not just from today's discussion, but indeed in some of our previous events and activities. Our citizen jury last year was very strong on the need for citizens to have not just access to their health information, but greater control over that information. And I guess that's a key question for us, in how can we empower that greater levels of control. And indeed, our previous events around electronic health records and how those can incorporate elements of portals into their systems. But without further ado, I'll hand over to Morten. You're very welcome. And if you'd like to give your presentation, and we'll take it from there. So Morten, over to you.
Thank you very much. Good afternoon, and thank you very much for the invitation. And thank you for your interest in the National Danish e-health portal, Sundhed.dk, and the app, Min Sundhed. I'll just refer to the portal as Sundhed, which means health. Maybe you know the German word Gesundheit, something like that. And also refer to my app as My Health. This is how the agenda looks. I'll start out by introducing you shortly to the Danish healthcare system and highlight some core factors which are fundamental to understand Sundhed and the app My Health.
Sorry, Morten, if I could just maybe just interrupt. I don't believe we're actually seeing your slides advancing. So if you maybe would like to just come back out of your screen share. Yes, we can. And then activate it again. Yeah.
Can you see anything now?
No, not currently.
Then I have to find out how to. I don't know exactly. Now I ask them to share. We just made a very, very good. We tried it very well for a moment ago, so I hope we'll find it again. So. Window. Yeah, I don't know exactly how to manage this because we
could definitely see your presentation slides, but they just didn't seem to be advancing. So what we've found in other events is that it just literally takes you to come out of your slide share, your presentation view, and then.
What about this?
Still can't see anything just yet.
Then it's not the right one I've got. I don't know exactly. I'm so sorry about this.
So we've had a comment from our good friend Richard Green on the chat. He says to put the slides on presentation first and then share, if that helps.
But then it's not possible for me to have the share button anymore. So
yeah, Martin, when you click on share screen, so do you have your presentation open on your screen?
yeah, you know,
okay.
it's open, but it's not fully opened.
Okay, when you click on share screen, do you have the opportunity to select the presentation window to share?
Yeah.
Okay, so try that. Great, and then if you go to the present, yeah, the present area.
Okay, like this.
See, it's still stuck in the kind of preview mode. So
yeah, it's then I have tried this before. I'm sorry, and then I can't do anything more. So I will send my slides to you immediately.
Okay.
And then you have to. If it's not, you can't. I have one more thing we can do. We can do like this.
Yeah, I can see that fine.
Okay.
If you're not able to go into presentation mode for, if it's not compatible, we can still.
I can't.
Okay.
I have tried this before. I don't know
Yeah.
why I can't do this step. I've tried this before in this Zoom media. We couldn't do anything. It was a European conference, and it was the same thing for every presenter. They couldn't go to the presentation mode. So if this here works for you.
Yes, I believe that this will work. Thank you, Morten. Yes.
Like this? Yeah. Okay.
Yeah.
Yeah, the agenda. I'll start out by introducing you to the Danish healthcare system and highlight some core factors which are fundamental to understand Sundhed and the app My Health. We then have a look at the universe of Sundhed and what our solutions offer. Also the changes during the COVID-19 pandemic. Both our portal and our app make out a central part in the Danish e-healthcare system and played a crucial role handling the COVID-19 pandemic in Denmark. I'll introduce you shortly to our user panel and how we collect information about our users. Finally, I'll mention the foundation Sundhed International. The Danish healthcare system is universal. It's based on the principles of free and equal access to healthcare for all citizens. And in Denmark, we have a long tradition on registration, and health data has been collected and stored in national health registers for more than 40 years. And we are talking about unique and exceptionally reliable health data from cradle to grave, from all hospitals, all medical clinics. So there are no gaps in terms of gender, age, or geography. And finally, we also have a unique personal identifier, a digital signature, and a secure logon to public services across sectors, also the private banking sector, for instance. And all together are very good building blocks to achieve a very high maturity within the digitalization. Another core factor which is important to mention when you talk about digitalization in Denmark is what we call the culture of trust. Danes have been used to sharing data and registration for years, and I could say for decades. And Danes widely trust the public sector and the healthcare sector's handling of their data. The majority have experienced the advantages of using public digital self-service solutions, how it empowers them, how it makes everyday life easier. So I could say today, Danes actually expect the public sector to provide good digital self-service solutions within all sectors, just as they expect transparency and access to their own data. I think to understand this culture of trust, this confidence among citizens, one have to understand that Sundhed is also political founded at all levels. It's a cooperation between 5 Danish regions, the state, and the municipalities. And furthermore, Sundhed is governed by its own political board with representatives from each of its partner organizations. So Sundhed as organizations have all its competences in-house. We have IT development, we have IT management, we have usability, UX, communication, all of it. This dimension about democracy and about health IT in general is very important, I think, when we talk about confidence and access to and also sharing clinical data. It's a model that ensures that data is handled within a democratic setting and that the data is owned and used by the general public and nobody else. Sundhed is strongly founded in national finance agreements and in national e-health strategies. Furthermore, we have our own strategy signed by our own political board. It's a result of a long, intense dialogue with our stakeholders, healthcare professionals, and of course, patients associations in Denmark, the IT industry, and others to discuss the direction and the content of the strategy, and also to discuss the goals for further development of Sundhed. So I think this strategy process is also about how we run this business. Now, let's have a look at our solution, our web portal, and our app. Sundhed is a universe of health, with the portal and the app as the central turning points, we provide fast and easy access to our EHR data from every hospital, every clinic, on PC, tablet, mobile phones, anywhere, anytime. Sundhed is for both Danish citizens and also for healthcare professionals, and have been a central part of Danish healthcare, I think, for at least the last 20 years now. It was launched back in December 2003. What is also important to mention here is the fact that Sundhed look up and display health data from national databases, from regional EHR systems, and the GP sector, and so on. Data is shown at Sundhed and the app when you log in. So, and that's important from a technical point of view, data is not collected, nor managed, nor stored at us. And what is more important, we reuse existing data from everyday production in healthcare sector. So data is not especially collected for Sundhed. We only show already existing data collected at the hospital, at the general practitioner, and so on. Here you see a few of the features citizens get access to in the closed area when they are logging to Sundhed. And it's either the app version or the web portal. You have, for instance, personal medicine overview. You have EHR notes from hospitals and descriptions of X-ray and scanning and overview of vaccinations, and also lab responses back in time, which became extremely important during the pandemic. You also can give authorization if you want that to another trusted person. It is intended for family members, and for instance, it has been very helpful during the pandemic because it really gives patient empowerment and the possibility to give a helping hand a new dimension. If you're 50 and your father is 80, then you can help him looking up his data and have the contact with the healthcare professionals. And let me shortly reflect on the fact that Danes have access to EHR notes from hospitals since 2010. And that fact itself is also forming the culture among healthcare professionals and the way they write notes. I still remember when we opened for this service, I had a dialogue with a midwife, and it was 12 years ago, and she said, "Oh, then I can't write that this woman should never be a mother." And that's for sure, or at least the midwife has to stand up afterwards for whatever she chooses to write. So the culture among healthcare professionals, how they write the EHR notes, have changed. We've been forming them with these services. Let's have a short look at the traffic within the closed area, and this is from January 19. And you can see the number of users increasing during the last 2 years with a peak during COVID-19. So we had 1.9 million logins in May 21, and it was only the portal. And the total number of visits at Sundhed is of course also increasing, reaching 9.8 million. It was in May 21. And remember, we are only 5.8 million Danes. So 9.8 million visits a month, that's a lot. We also in Denmark have a citizens portal for every sector and for everything in the digital Danish universes. And they had 70 million visits last year, and we had 85 million. So though we are only a sector portal, we have more traffic than the general portal for citizens. Okay, that was short about our portal. Now let's have a look at the app, which I told you we call My Health. With the app My Health, you have access to a slimmer and a more user-friendly version of the portal. Both give access to lab responses and provide Danish citizens with the Corona passport. As you see, the number of downloads explode in spring 21 when we first time reopened Denmark after the Corona lockdown. Today, we have now reached that more than 5.2 million downloads of this app. And again, this is a very high number of users in Danish context with approximately 5.8 million inhabitants. Here you have just a short glimpse of the Corona passport at My Health, a service that in many ways is a result of an accelerated developing process on top of what we already had and exploiting the advantages that was already present during 2 decades. The right building blocks were present, and it made it possible quickly to develop another block, and in this case, the passport. And as mentioned, Sundhed is also a tool for the health professionals. They can look up patients' data and access, for instance, doctor's handbook. Health professionals can either log into Sundhed directly to look up patients, or they can even work from their own EHR system and look up personal clinical data at Sundhed via a link. So of course, Danish healthcare professionals work in their own critical EHR system at their hospital or in their clinic. But this is an example from an regional EHR system, and also an example here from the general practitioner. And we count, when we talk about general practitioners, they have 70,000 lookups a month, and that at least 2,000 a day. And also from the hospital's EHR system, we have 70,000 lookups a month. So it's 150,000 Danes a month who has been treated looking up Sundhed as the EHR system, as the extranet. And it is because maybe the doctor is not at his office, and maybe he is on vacation, but suddenly he has a patient in front of him. So everywhere, anytime, you can look up every patient's data. It's very good tool if you're fainted out in some unpleasant surroundings. So this is a good example of Sundhed as an integration point or integration platform, and how it also is an extranet if you don't have access to the patient's data in your everyday EHR system. So let's have a very short look at the Danish IT infrastructure, how we manage this. It's designed to support sharing data and collaborations across sectors. Through shared technical standards and interfaces, exchange of data across different systems is made possible. So interfaces for integrations, web services are kept updated and alive, ongoing in different systems, and solutions can talk together. So this model, and I think that's important, this model leaves room for local innovation and IT development driven by local needs. You can choose whatever IC supplier, Epic or whatever it's named, or whatever system you want at local, at regional and national level. So Sundhed makes out the glue and support integration through interfaces always updated. As mentioned before, the national strategies ensure a common framework for digital solutions within Danish healthcare. So from a technical perspective, this is also a core factor to understand Sundhed. And I have to mention one more thing. Sundhed has been developed step by step since 2003. It's not a result of any Big Bang approach. And Sundhed is not to be seen as one solution. Actually, Sundhed is an integration platform. From the moment we are showing data from more than 120 different data sources out there, hospitals, laboratories, whatever. So this, of course, makes even greater demand on a user-friendly approach because we mix all those different data sources together. And to ensure services and information that is spot on and are user-friendly, we depend on a very close dialogue with and feedback from the users. We collect huge amounts of information about our users, user statistics from the portal and app, and from various kinds of surveys. We translate data into this kind of overviews, so you can choose whatever you want, and it's a good way to communicate and use our findings. And very recently, we launched what we call the Sundhed User Panel. Everyone in Denmark and with interest in making Sundhed and My Health better can join this panel. Citizens and healthcare professionals, and more than 2,000 for the moment joins this user panel. And this gives us easy and fast access to a user-centered dialogue when we develop new services or in launching, for instance, a new campaign. Then we can ask, how does this look for you on beforehand? This user-centered focus is necessary when we want to be a user-centered health universe, as stated in our strategy. Okay, we are now at the end of my presentation, and this is the very last thing I find relevant to mention is the foundation, Sonadeco International. It was established years ago. It's called Sonadeco International, and it was a result of a long-lasting international interest in Sundhed as an, I think, international frontrunner. By the way, for the moment, we are planning a national entrance for patients' organizations and their concealing on Sundhed. So maybe that could be of your interest for a deeper dive with the foundations and experiences and maybe have some help. So based on our experiences, the foundation especially participates in establishing healthcare IT solutions in international context, private or public. So please reach out if you need to. And thank you very much for your time.
Thank you, Morten, and thank you for your excellent presentation of what looks to be an excellent solution that is producing real benefits in realizing benefits for Danish citizens. I can't help thinking just from an Irish perspective and what we can learn of all the gaps that currently exist in our system that maybe are currently in place in Denmark. But I think one of the key gaps is, I guess, a remaining question, which is the theme of this whole session, is around how do we involve patients and indeed the public in the digitalization. So that can range from accessing your health information in the first instance, but then also being part of the agenda and being part of the prioritization and indeed to drive the agenda would be a key question from an IPPOSI perspective. And I'd really like to get our panelists kind of invigorated on those topics. So without further ado, I'll go straight to our multi-stakeholder panelists, and I'll ask you to activate your cameras. And just to give a quick overview of our panel response. So for the next 30 minutes or so, we have an opportunity for our panelists to respond to Morten's presentation and to provide insights into the utility of a portal to meaningfully contribute to patient outcomes or patient's experience, but also consider the frameworks that exist from a policy or a funding perspective to implement a successful infrastructure in Ireland. And we have two people coming from St. Patrick's Mental Health Services that has rolled out a portal in more recent years, and that's both we have Orla Gogarty, who's their Director of Digital Health, and also Adrian Yates, who's an advisory forum member, a service user advisory forum member of the portal rollout. We're also joined by Cora Flynn, who's an epilepsy nurse specialist in St. Vincent's Hospital and has been directly involved in an epilepsy patient portal as part of a HRB funded project there. You're very welcome, every one of you. And we're also joined by IPPOSI board member, that's Professor Gay Stevens, who is a lecturer in Trinity College Dublin and in the area of health informatics. So without further ado, I'll go straight to maybe Adrian Yates. So Adrian, you've heard a lot there from Morten from the perspective of someone who has been involved as an advisory forum member in the St. Patrick's Mental Health Services. What's your response to maybe what Morten has painted there for us today?
Yeah, hello everybody. Thanks, Derek. And first of all, sincere thanks to Morten. Absolutely fantastic presentation. And I suppose as a service user, I don't wish to be cheesy or anything like that, but I'm blown away. I think it's the most amazing thing. If I was to try and imagine utopia for a patient, that comes pretty close. I got involved. I've a long history with anxiety and depression, and therefore have been a patient at St. Pat's a number of times. And I was very anxious to get involved with anything that would kind of help me to give back, if you like, in terms of other people's experiences in working with the hospital and so on. And when they said they were looking at rolling out the patient portal, I thought that was a really good idea and something that I could probably speak to, having a long history in business as well. I think for me, what's really, really important is, a number of things that have come up on citizens jury and so on. And, the things that speak strongest to me immediately are around empowerment. I'm probably of a life stage now. When I started out in life, doctors were all knowing. If you were ill, you went to your doctor, they prescribed, and you did whatever it was they asked. And so it went on. I don't think I've ever seen my doctor's records all through my life. But certainly as part of managing a mental illness, I think with some of the repeat episodes that I have had, I kind of felt if I knew a little bit more about what was going on, it might actually support me in my recovery and so on. And that's very much what I have experienced with the patient portal at St. Pat's, is that I have direct access to the information that I need on the advisory forum. We're given scenarios and asked for input, which I suppose when you compare what I explained about my medical doctor, you were never asked for your input on anything. So, I think that's really, really important for people to be able to take more control over their own information and have it in an environment that's really safe. Two words I took from Morton's presentation. The first and I think strongest one is trust. You have to have trust between both parties. And I think, probably in the Q&A, there may be questions around the security of the information that's held. And I think it's something that Irish people in particular are maybe suspicious is a bit too strong of a word, but I'm not sure the culture, that's the second word. I'm not sure the culture is there yet in Ireland to depend as heavily on the state as it seems the citizens in Denmark are. So, I think, for me, what we're doing and what I'm seeing at St. Pat's has been tremendously beneficial for me. But I'd also take on board what was said, that, this panel that was discussed also over 2,000 people, it's a living thing. And that's really, really important. I'm looking at it from a mental health perspective, but the idea that this is for all of your health, and that it's all integrated. I mean, I think it's absolutely amazing. So, I don't know what else I can say, but, I think if we can move in that direction in Ireland, and, that seems to be the will. And, again, the citizens jury have come up with, some of those key principles within there. I think they are. And I love the idea of building blocks. And it was one of the discussions we had on the St. Pat's system. If you just dump everything, it's overwhelming for people. So that you can kind of ease yourself into the portal and understand how to best use it for yourself. You may not need access to all the information all the time, so it's kind of modular, and I think that's really powerful as well. But yeah, no, I think it's amazing. Great work.
Thank you, Adrian, and thank you for your very informed response. And it'll be very interesting to see if some of maybe the culture changes that Morton has presented there can be replicated in Ireland, indeed, through the use or the increased access and empowerment of patients. So I'll go to Orla Gogarty now. So Orla, if you could maybe give it maybe a little bit of context to where Adrian has spoken about the portal that's available in St. Pat's Mental Services, but also what your overall reaction to Morton's presentation is. Orla, you're very welcome.
Hi, everyone. Derek, thanks so much for inviting me to be part of this panel. I have to say my first reaction to Morton's presentation is inspirational. Obviously, Adrian's referenced our journey in St. Patrick's in a small way, but listening to Morton, it tells about a story where positive technology in a positive way can really empower the patients and service users to have access to the information that they need. But it's also, I found it quite validating because we've only started more recently on our journey with our patient portal, our service user portal, but it appears like we're going in the right direction. So thanks, Morton, for that. And I would love to reach out to you maybe at another occasion to focus on maybe an international discussion, because we're in our infancy in St. Patrick's. But just to tell you a little bit about who we are, obviously Ireland is a different, takes a different approach to the provision of healthcare. We don't have a single unified public health service. We have it's two-tiered. We have a mix of public and private, and therein lies one of the challenges in the first instance about having a standardized approach to a patient portal. For St. Patrick's, we've been around over 270 years. Jonathan Swift founded us, and we are not-for-profit, and we're an independent service provider. And that provides us with some advantages in terms of making speedier decisions and focusing on, strategic projects which we can really put our shoulder behind. Just also to say, which is really important, and Adrian has referenced it, we believe in a rights-based approach to this provision of mental health services, and that rights-based approach is infused to everything that we do, including, service users sitting on all of our interview panels, service user advisories, guiding us on all strategic projects, not just alone our EHR implementation and patient portal implementation. So our service users are front and center to what we need to do in developing and delivering our services. Adrian has been a really valuable member of our advisory, and thanks, Adrian, again for being part of this panel discussion. It's really, we're really grateful to you for doing that. What I'd say about our own experience of the patient portal, and we call ours your portal, but everybody will call theirs something slightly different. I assume Sundek has a nice ring to it. I like the reference to the health in front and center too. We implemented an electronic health record in 2017. We had that bedded in for a good number of years, and it was, we didn't take a modular approach in our EHR. We went big bang, so it was well embedded across the organization, our outpatient, outpatient, and inpatient pathways. But when COVID happened, we decided we were going to make a really important decision and do a rapid deployment of our patient portal. And we had gone out the previous year to the market to purchase a portal, the technology element of the portal. But that really was ready to go, and we pushed for rapid deployment, specifically because we wanted to reduce the footfall on our campus to protect people during COVID and to protect our staff, but also to provide service users who weren't able to attend in person and to have access to their information. Are we fully there yet? No. What are the biggest challenges for us? Well, the biggest challenges for us in terms of the rollout of our patient portal is clinical engagement and clinical adoption of systems. Our service users they're there. They get the whole imperatives around having access to their information. They're very involved and very invested in this journey with us, and they're the ones that are driving us. I suppose the other challenge, and Morten, you referenced it in your conversation with the midwife, is how clinicians document is sometimes not aligned to how service users need to have their information presented to them. So we need to do work around the alignment of that. And in Ireland, there's an organisation called the National Adult Literacy Association, NALA. We have worked with NALA to develop a guide to help clinicians change how they write. But that's a process. It can't happen overnight. But it's an important part of our rollout. Another aspect, another challenge has been data governance and information governance, making sure that the processes and policies and standard operating procedures to ensure that the quality of the data that is put into the EHR, which is linked to our portal, is checked and reviewed, and this constant continuous improvement process in place. We're excited about the next phase, which really is pushing towards the sharing of treatment plans, and also for service users to have the opportunity to update their treatment plans, so that there's a dialogue, a dynamic dialogue between service user and multidisciplinary team. Our portals are actually linked into the EHR, so all of the information is pulled from the EHR, and all of the information that the service user provided back into it is pushed into the EHR. But we do have some mechanisms in place for that information to be reviewed when it's coming from the service user, that because it'll become part of the record, we have some quality checks that we need to have in place. And I really like the idea of having a standards-based approach to how we use technology in healthcare rather than the centralized one system pushed down to everybody. And certainly in our own organization, standards-based approaches is what we're focused on. I think we need within Ireland, like St. Patrick's is one organization. Within Ireland, there is, I think, a lag between the policies and standards versus the technology. In other words, the technology is rushing ahead in a way. And that speaks to the other piece of what has been discussed already, is the need for a culture to support the implementation of a portal. And what is culture? You know, when we strip culture down, it's what we do every day. It says something about the values that are imbued in the services that we work for. And that's why I think in St. Patrick's, you know, the rights-based focus, the focus on empowerment and collaboration, they're washed through everything we do. So in terms of approaching the patient portal, it didn't feel anything different. It didn't feel like it was grating against what we do as individual members of an organization. It felt right. And I know that the team that I have working with the service user advisory, they've loved that work. It actually gives them joy, that part of working with the service user advisories and really refining and defining how the portal will be rolled out further and optimized further into the future. So that's really the short potted history, and look forward to the further discussion.
Thank you, Orla. Thank you very much. It's certainly an initiative that in IPPOSI we've been following with great interest, and certainly in terms of the development of the portal and the continued engagement with your user panel, I think it can only really get better, really, because as you say, you've probably started from a good starting point. It was interesting from Morton's presentation that your user panel came many years after the initial development of the portal, and be interesting just to see, you know, the stages that happen and what benefits that user panel is going to realize in the near future. But with that user-centered focus and maybe a patient-centered focus, I'll turn to Cora. And Cora, your experience with the epilepsy patient portal, certainly in Beaumont Hospital, and the likes of Mary Fitzsimons and others who have been involved in that project for many years, would be familiar to, I think, to an awful lot of IPPOSI, certainly our patient members. So from what you've heard today, could you give us your perspective as someone who's really at the coalface within the public hospital system in terms of the utility of portals?
So thanks, Derek, and good afternoon, everybody. And very envious and a green-eyed monster here looking at your beautiful electronic patient record in Denmark, which is a very similar sized country and similar sized demographics as Ireland. And your starting point in 2003 was our starting point in 2004. So along that journey, we have grown, and it wasn't until about 2019 that we opened up that portal. And that was very much a pilot of a portal at Beaumont and James's, which I wasn't completely involved in, but it just opened our eyes in how much people can co-design and cross-check what we do and help us really to make sure our information is accurate, because sometimes it's inaccurate. And it was very much a learning piece on how we share information. For people with epilepsy, they can often have memory difficulties. So it's really nice for them to be able to look up their information, and it reminds them, you know, of certain, you know, maybe words that they didn't understand, that they didn't get an opportunity to ask a clinic, that they can go and maybe Google and become a very knowledgeable person, you know, with their health system. I mean, what I would love to see with e-health systems is real contribution from the public in the demographics part and being ownership of their own appointments in one sense. I mean, you know, we can pick up a phone and get a hair appointment. Why can't people have their own responsibility for their appointments. So there's a huge amount of learning there between the people and the users. I mean, from my perspective, the eHealth solution that we designed was in a modular form, and we were learning as we were going, because it was very much a research project where we were looking to see, could we improve the delivery of epilepsy care with an eHealth solution. A lot of the work I do would be on the telephone. So from a telehealth perspective that everybody's been exposed to during COVID, without an eHealth solution, it's really challenging. And people find telehealth very accessible. They don't have to attend, find parking, get frustrated getting that parking, and then wait in that outpatient room. Much easier for them to pick up the telephone and get their medications reviewed. And we can't really do that without an eHealth solution. And during the recent cyber attack, that posed a lot of challenges. And we just realized how beneficial eHealth is to people and users alike. I've lots of questions really for Morten, rather than going on about our own eHealth solutions, but I'd really love to hear from him about whether patients were engaged right from the beginning and really building that culture of trust and that ease of use and getting people comfortable with it, both from a clinician's perspective and a patient's perspective. So I'll hand it back to you, Derek, because I'd love to hear more about their experience.
Thanks, Cora. And before I turn to Morten, I'll probably just invite our final panelist, Gay Stevens, to join the conversation. And Gay will be familiar to many IPPOSI members, but also through the work we've been doing over many years in terms of electronic health and in the broader area of health informatics. Gay, how do you see the kind of the patient portals or the citizen portals actually within that kind of broader eHealth environment in Ireland, in terms of where they're currently at and where maybe what we've learned already, where they could go?
Yeah, thanks, Derek, and thank you very much, Morten and Adrian, Orla and Cora. I think it's fascinating to look at what Morten has presented to us, and just even from the point of view of saying it's possible. We sometimes go into this where, this is impossible to do, but actually Morten has just shown us it is possible. It is possible across many different providers of IT systems, so if a standards approach is used, it is possible. And I think in terms of, say we imagine it's possible and it's possible in Ireland, I think it's if we had a portal or multiple portals, I don't even know if there's just one, but multiple views on all of this information, it's the beginning of a change, I think, of the relationship between patients and the healthcare professionals that they link with, because we don't fully understand, I think, what a patient or a citizen might do with this information, or how a clinician might respond, in maybe correcting information that's on a file, or a negotiation about care, and treatments and things like that. And every citizen is different. So the portal should be allowing for a conversation to go in many different routes, while still keeping within, obviously, the scope of practice. So I think it's that might change. It's that potential for a citizen to become engaged and to change it for the better and for the citizens themselves. But if I look maybe just to some of the challenges that we would have, and comparing to what Morten has presented, we don't really have very much developed legislation in Ireland around health information. So it can be very hard to even begin to build trust, because we don't know where we're starting from. Even if we had bad legislation, we could start with it and start pulling it apart and saying, this is not what we want. So people can be uncertain of how to jump into the world, because that boundary there's no boundary there. And it may seem very obvious to say, but the information has to be in digital format to go into the portal. In a lot of places in Ireland, we don't have that information in digital format. And it's not just a matter of, we can scan it in or we can put it in, because there's a whole processes around that manual thing that we have at the moment and the paper-based system. So it's a huge change of practice that needs to happen. And maybe just finally a challenge to say, and to go back to what Cora was saying about the epilepsy portal and record. I was involved many decades ago at the very start of that epilepsy project, and the very first thing we have to do is look at the information that's being used, and if we're going to go across services and with the ambition maybe of going public-private, do we all mean the same thing when we say even something as simple as date of birth? Are we all coding it the same way? Are we all using the same terms across it? There's a large amount of work to be done in that area too. And that's not even beginning to open it up to the type of information that a patient or a citizen may want to put in to the records themselves. But I think, it is possible. I think that's the big takeaway message from me today. It is possible with many disparate systems to do it. We've seen it here with our own COVID vaccine app. It's possible in Ireland for us to do it. We got legislation there. It came together. So it is possible. We need to do it in bit by bit. I think bit by bit is better because it allows for that evolution of partnership with the patient. And also can't even imagine the things we might want to do with it. So it allows for, it's a much more ethical way, I think, to do it bit by bit and to continue the citizens' jury engagement. That's not a once-off thing. That has to keep recurring and keep going back and us, joining together, as Morten has demonstrated also in his system. So thanks so much, Derek.
Thank you, Gay, and thanks again for your own involvement in this area. It's just been great to have your extensive experience over many years. Very often probably rolling the ball up the hill and coming back down again to roll it up again. But I'm struck by the commonality between the different perspectives here, and certainly for the other participants, I would openly now encourage people to start using the Q&A function just at the bottom of your screens. If you have outstanding questions, please post them there. I know there's a couple coming through in the chat box, but excuse me, before we go to those questions, and I'll give people time to formulate their own heads, I'll go back to Morten with those kind of specific questions to you, Morten, particularly around that culture and that kind of relationship between healthcare professionals and service users or patients. Do you have any kind of responses from what you've heard from the different Irish-based stakeholders?
Yes, and firstly, thank you very much for those very inspiring reflections all over. I think you have already started with those reflections, so thank you very much for that. Then I will ask in two directions about the thing about culture. First, I will broaden up, and then I will narrow down to make it possible to have to cope with that also. Because I think if you read reports also from, for instance, Sweden or Norway, they will find some of the same words about consent and about culture of trust. And I think it's closely connected to having a culture of transparency and democracy. So when you go to kindergarten, you are always engaged in the board. So you know that when you are paying your tax to the municipalities, it goes for kindergarten, and you are yourself in the board. The same thing with the public school, and the same thing with the healthcare sector. You find this kind of co-ownership, and you find yourself as a co-writer when you're patients, because it's your money. It's paid. It's common good. It's paid by your tax, and we pay actually a lot of tax in Denmark, 60% or more. So that's maybe a difference. And I think that those thoughts about culture of trust are in some kind very much related to, for instance, Scandinavian countries. You also find something like that in Holland, maybe. I've actually been part of an WHO panelship. I've been some kind of expert this winter about this culture of trust thing. And they ask me again and again. And then they also tell me, please, Morten, don't tell all of us to be social Nordic democratic welfare states to have a portal. And I think it's so precisely said. Of course, it should be possible to take all the technical digital advantages without having a specific model for your society. So So they have asked me again and again, and also in this foundation we have established for international purposes, not to repeat that you have to have this social democratic Nordic welfare model before you can make a portal, because it makes no sense. So I think instead I will take my answer to what I talked about. For instance, the user panel. For instance, this engagement of the end user perspective. And should I make a startup in Ireland, as you are trying to with this, I will take very much in the thoughts from your patients' organizations. I will really ask those who should be the end users, what do you want? Also, if you don't have all registrations from the beginning, if you don't have EHR in every hospital, if you don't have lab responses, laboratories out there making good figures, then start with whatever you have. Try to show the patients of the hospital what you have and ask them, does this make sense to you? And if not, change it a little. And when you have a success, then you can spread it out. Because one of the core values of Sundhed is that we are using the data that are already made in everyday production in healthcare sector. And as I told you, Danes have this trust in kindergartens, in public schools, and in healthcare. It's because they have trust in what the doctors write about them. So sharing what they trust is having this culture of trust. And you also, I think you also saw it during the pandemic that Denmark have very high rates of vaccination, because the prime minister in this case actually told us, please have a vaccination, please stay home, please do that. And Danes are very, they rely on those public authorities. So that's part of it. But if you don't have that high degree of believing in public authorities, then you should rely on having a strong relation to the end users. Having this panel, having all those questionnaires, ask, involve, and only make things which are usable for the patients, for those who should be stronger, for those who shall help you staying out from hospital, is being strong, be empowered, help them to be empowered. That's how you think about it. Then you can have this relation of trust if they are better off afterwards.
Thank you, Morten. I might just press you on one of the questions there that's come through, and it's one of the comments from Cora around the demographic information. So it strikes me as a really, really good opportunity. We talk about opportunities for patients and the public to get involved in this. If in Ireland, even our demographic information is not up to a certain standard or is of a certain quality, do you think that, okay, in Denmark, it's you know, the infrastructure is you know, it's embedded within the healthcare system, but it strikes me that is a good opportunity for Irish patients and the public to actually engage with even very simple information to ensure that it is correct in the first instance. Is that something that in Denmark you offer in terms of patients maybe being part of the audit of a record?
The audits, I have to be sure that I really understand the question. If they have to be part of the
the audit, so ensuring that the data in their record is actually correct.
That's a good question. If you have any doubt, you can ask your local hospital who make the data if they're correct or not, but you can never change them. We have had some very specific cases also with big public interest and radio shows and so on, because they actually people have actually, when we show their EHR data, found some errors, but then it's not possible to correct an error. If it says you have some kind of sexual disease and a person don't want to have that in his EHR because maybe it's not right, then he can't have it corrected, because some doctors can have had some treatment who have relied on that. So if you change it, they have done something wrong, and we can't bear that. So you have to have a new statement from this state that said, okay, what we have been writing down there is maybe an error, but it still has to stand there. Does that make sense? So you can in some way make the patient, the EHR system better and more correctly, but you can never delete errors.
Thank you, Morten. I'm struck by your answer because I think it's highly relevant in the context of the mental health information that maybe
Exactly.
Orla and Adrian have been working with, and particularly if you feel that certain information is either not suitable within or can only be restricted. It was certainly something that came through strongly from our citizens jury recommendations about this locked box concept. Orla, I see your hands up. Do you wish to come in at this stage?
Yeah, actually, it was just in response to what Morten said about, I completely agree. You'll always have an audit trail of data, how data is changed, and that's really important for the transparency in terms of, how is my data being held, updated, and etc. One of the things that we did do in relation to our role into the portal is we looked at a mechanism for getting service users to validate their demographics. So in other words, giving them access, letting them check, is my name written correctly? Is my address correctly? And who would have thought that during COVID that your actual email address was the most critical contact information? We were surprised by that. Making sure, just validating that the information is correct. And it's a continuous process. It's not a once-off, it's continuous. So I suppose there's a difference between data correction and data validation. And that can be driven through the service user giving feedback and updates.
Thanks, Orla. Good to know that functionality actually exists in the first instance. Cora, do you wish to come in? Sorry, Cora, can't really hear you.
Sorry about that. Just two things. I'd like to reiterate what Gay said, really important to have standardized information, both clinical, demographics, laboratories, rubbish in, rubbish out. I'm sure we've all heard that. And if we want data-driven services, we all need to be talking the same language. But a question I'd like to pose to Morten is, does he know what percentage of the overall healthcare budget is assigned to the maintenance and sustaining the e-health program in your country?
I don't have any specific figures how many money, but when we have a national strategy, there will also be some money. But very often I'm asked about the budget and how much does this cost. And actually, this model about making an integration machinery like Sundhed has been very cheap. I think that the budget for opening the portal was 8 million euro. 8 million euro to buy the platform we made for integration. And then our budget had been about 8 million euros a year. But when you know what it costs to have Epic in one county, in one region, or what it costs to whatever, it's so cheap. It's so cheap. Actually, I'm in Germany. I'm taking part in an advisory board. They are trying to connect 18 university hospitals with a Sundhed model, and they are doing it with a hospital in each Bundesländer. So they have 18 Bundesländer connecting on this Sundhed. They have a budget on 115 million euros. 115 million euros for doing that. And they have chosen a model where they are more specific about the data. It's not only an EHR. The data are so much leveled out that they are more directly usable also for instance, research on very specific topics. So that's another model. But I think the root one, the Danish one, where you use the data that are already existing, can be very cheap. But it depends on that you have some data out there and you have some EHR systems to integrate to, that you have some laboratories to make integration to, so you can show the data from there. But if you have some reasonable level of some figures you want to show back to the users who actually own them, then the Danish model is actually quite cheap.
Thank you, Morten. Cora, do you wish to follow up?
No, I mean, 8 million, it sounds very cheap. I'd love to know what percentage of that is the overall spend. And maybe Orla might like to contribute on that, sort of what was the spend, you know, within your organization from implementation and sustaining.
It was a lot less than 8 million. So just to echo what Morten said, and I think you made a really important point, your approach has been that it's almost like an integration engine, which, you know, we use an integration engine in St. Patrick's, which links not just our EHR to our portal, but it links our EHR to our laboratory, it links our EHR to our SMS messages. So, and that's reasonably cheap, you know, as a technology goes. Our portal, which was where we had an EHR untethered to anything, so we had to buy an extra portal. That was quite cheap. God, it wasn't even 500,000. Like, you know, it was cheap relative to the value. But you have to have data. There's, you know, it can't be just swinging in the air. You know, it has to be connected to data. So obviously in Denmark, you have data in registries and EHRs in your laboratories. So you're just making it, you're unlocking the value of it. And the value, it should be all about creating value for the service user to take responsibility for their own health in as much as they can. So we've all grown up now with Fitbits. How many of us have iPhone health apps on our, you know, citizens are beginning to expect this, not just of their consumer, you know, the products that they buy for themselves or their family, but I can see how in Denmark, the citizens' expectation of having access to their own information, when you have that culture of trust and empowerment, would be quite high. I'm not sure if the citizen expectation is matched across all stakeholders in Ireland.
Thanks, Orla. Adrian, you want to come in there?
Yeah, I just wanted to make a quick point regarding, I suppose, the impact of COVID on all of this. And, you know, all things being equal, I think it would be a very difficult thing in Ireland, just with the culture that we have, what we've referenced so far. The fantastic part of what Morten said is that, you know, we have that phrase, if you can see it, you can be it. And I think now that the inspiration is we can actually do something like this. My fear would be that, you know, different people would start doing different solutions at a different time at a different rate, rather than that integration piece that was referenced earlier. And, you know, sometimes the sense is there, oh, we can't do this. And the piece from COVID that really strikes me is, as a past employer working in a large multinational company, if you asked me 3 years ago, would I be allowing my staff to work from home on a flexible basis, I would have said no. Then along comes a thing called COVID-19, and within 6 months, practically everybody is working from home. Now that's a very dramatic, powerful external influence. But what it does is it says, where there's a will, there's a way. Things that seem to be impossible can actually be done. And I'd like to take that kind of, if you like, inspiration for Denmark and put it against that backdrop and say, because more and more people, my mum is 82, I hope she doesn't get to see this, I shouldn't be saying her age, but I'm only doing it from the point of view is she had no interest in technology before. She now has an iPhone, she's on Facebook, she's on WhatsApp. You know, a lot of people will say, oh, sure, everybody doesn't have a phone or everybody isn't interested in technology. But actually, people want service, they want access, they want their information and that sense of control as well. And again, within a very secure environment, I think it works really, really well. But I think we've been forced to. Like, I mean, which of us had heard of Zoom 3 years ago, 2 years ago? And yet we're living on it every day. So, we can adapt very, very quickly to these things. So I think, let's try and take the positive and push forward on that basis. Thanks.
Thanks, Adrian. Great example of where If you can see it, you believe it. The Gay, you wish to come in? I'll go to Gay before I go to the Q&A. I see there's a couple of questions there.
Okay, so maybe just to echo a little bit what Adrian is saying around, your query of, are we all going to have separate little portals, around the place, and they're not going to integrate? And just to, I suppose, a shout out to the health IT community in Ireland. It actually is quite a big force there, and a very positive force, a force who are willing to put their shoulder to the wheel, in many different instances, from the HSE, to HICWA, the Mental Health Commission, individual clinicians, patient communities. And there's a huge enthusiasm, but it seems to just get blocked. I don't know whether it's through funding or political, or there's something that's stopping it. But we have a great community out there that can prevent those little silos being created. There is a plan there, but it isn't followed up by government for some reason. So I think we should have faith in the IT community within the health service, that that thinking and reflection is there, and that with the citizens' engagement in it as well, we really have a very good base for doing something that isn't going to be siloed in the future. But it does depend on the will and the legislation.
Thanks, Gay. Great example there of, well, certainly we would have many people over the years have engaged with IPPOSI, both from science, industry, and patients, and certainly those who are, I think in general, we would see a pattern between those who are engaged and motivated around health informatics, also being particularly motivated around patient and citizen engagement. There's actually we would find a direct correlation between the two. So I'll go to the Q&A, and there's a couple of questions in here being directed specifically for Morten, so I might just go straight to them. Morten, there's a question from Richard Green. Do you use a state-based identification system for your patient registering with the portal? And can patients have access to all of their information if they wish?
First thing, we rely on what we call the personal identifier. Every Dane's got a CPR number, personal identifier, when they are born. On that, we have built what we call a digital signature. I think in 2010 or 12, we got a big rise in our traffic. It was due to that on beforehand, this digital signature was only for the banking sector, and another one for the public sector, for instance, libraries and so on. But then there was a cooperation. So now it's the same digital signature for insurance, for private banking, and for all the public sector. And after that, people really do rely on that because it is the solution you use for that. So that was question number one. And question number two, yes, actually, the most what we have been most busy about is not hiding data away from the citizens, but it is that the citizens have a possibility to hide away the data from certain healthcare professionals if they don't want it to be shown. So you can be specific if you don't want your data from a hospital shown to a doctor from another hospital or something like that. You can blind it. It's not very much used, and I'm lucky about that. I'm glad about that because if you blind it and you one day faint out and you are on an emergency, then they can't open it. Then they should do something like breaking the glass with a hammer. It is possible, but it takes time. So I think we are happy that not many Danes want to blind data, but it's actually possible. And what we have been building out, especially our former government was liberal government, and they want much of those rules. And I think it's fine. So the people themselves can choose what they want, but not many have wanted to activate that.
Very interesting. If I could just maybe follow up with a more precise question there. So my understanding then is that in the portal, patients and citizens have access to the full clinical notes as well. That's all fully available if people wish to view it.
Yeah.
Okay, that's great. Okay, another question coming through, this time from Anne Cullen. So how did Denmark address issues about the uniformity of data? So she's asking, was there a day zero from which patient healthcare data was collected and that historic healthcare data was uploaded retrospectively?
It's a very, very good question. And I think that data was not in the beginning made because we had this portal. Some data are in registration from 50 years old or 40 years old. And for instance, your medical history, it shows what hospital have you been to, where were you sent afterward, what you're diagnosed. Very, very few data. It was actually, now we have remade some data from even 1977 and made them digital. At that time, they was written in a book, but now we have made them digital. So we have been back in the future and reinstalled the data in a digital way. But I think that the work with having EHR data from hospitals have been stepping forward. So I think after 2010, every hospital and every ward at the hospitals had their own EHR system. So from then on, we showed it. But in the beginning, and it was maybe 2007, it was the first time that we showed EHR data. It was only one county, as we called them that time, Viborg in the middle of Denmark. And then they worked as an inspirement. And the others said, oh, they can show the data to the public. Whoa. And then we helped them and made those, I think, cheap integrations and began to show them. Then it was one county, then it was two counties, then it was western part of Denmark, only missing the capital and so on. So it spread slowly, but it was decided that everyone should be there in 2010. And then I think that we have not rewritten the data that was after 2010. But as I told you, I think we have formed the culture. So we have formed the way that the healthcare professionals write it. Of course, it should be for them and for their colleagues. They should rely on those data making the treatment. But still, you can twist it. You can write it in a way so it's also possible for the citizen to understand. And you must at least write something that you are sure about, that you can stand up and say, that is what I mean about this patient.
Thank you, Morten. Another follow-up question actually is coming from Lorna Kieran. So Lorna asks, can citizens access their genomic data in Denmark? And if so, was there any public consultation or patient involvement regarding this?
We have a genomic institute, only 2 or 3 years old, and they are still newborn. So for the moment, it's not possible at Sundhed to look any data up. But I think if there is any data, it's possible to ask that center if they can have the data. I will think so. I'm not sure about the way I answer this question. But I think it's more, can I get rid of those data if I don't want to see them? Maybe.
Okay, great. So there's more questions coming through, but I'm just curious if any of the panelists wish to, just from any of the questions that have come through, that if there is any from your own experiences within the Irish system. We've 10 minutes left, so please feel free to give as much to this as you possibly can. Yes, Orla, jump in.
So I just really wanted to comment about the unique health identifier, and Gay mentioned a number of things that we need in place to enable Ireland to move forward in a positive way in this, and the legislation is one. We have talked about and we implemented an individual health identifier theoretically I know our EHR, I think we were talking about this, Cora and Derek, on the call the other day. Most EHRs have a field that you can change to include a unique health identifier. We don't need to create new systems that have, are bespoke to an Irish health identifier. Most EHRs are flexible, but I think that's going to be really, really crucial. And we would love to have it enabled, and accessible for so every service user that comes to our service user could start using their individual health identifier. What I think has been unhelpful in Ireland, unfortunately, and you might remember the Office of the Data Protection Commission adjudication on how the PPS number, the personal social security number, can't remember, the PPSN number was used by the Department of Social Protection. So there was a challenge to that. And then that sort of closed down how we could use numbers like that for other systems. Well, I think it's going to be so important for us to have a truly integrated national system, whether it's public-private provider, sharing information we need it. And I also think that Morton has referenced choice. I think choice and flexibility has to be built into any system. So about, whether it's the service user to the portal deciding who they share their information with or who it's visible to with, that needs to be a pillar, a fundamental principle.
Thank you, Orla. Gay, do you wish to respond? Yep.
Sorry, that was half a mistake of pushing the button because it's a different topic, but I'm always concerned about, that we've a portal and now we've access to information as citizens, and we're all going to be the best citizens and the best patients and the most engaged, and we're not all like that, and sometimes we don't want to see our information, we don't want to know about it. And I just wonder, Morton, have you experienced that patients who don't want to engage, it's harder for them not to engage now, and they can't hide, and because I think that we should be allowed to do that. We all have our different routes, and at different times we want to see different things and engage in different ways.
It's a very good question, because new technology can be very stigmatizing, and especially for those people who are 80 years or something like that. But today, actually, those who are the traffic is rising most about those who are plus 65 in Denmark, but they was also only 15 years when we began all this, so they have some kind of digital education. But still, a lot of people being 80 years old don't want this, and especially for instance, my father, he didn't bother all this. So then he asked the citizen's office in his municipality to have letters in paper, and then he have letters in paper. And I'm a little proud that 2 times Denmark was ranked #1 by WHO in public digitalization, and we are not technical more better than anybody else, but we have 2 times they said it's because you still take care of those who don't want digitalization. So you're #1.
Thank you, Morton. I think, Cora, you wish to come back in?
Thanks, Derek. It's just a thought, but I think, do we have a lot of similarities with the banking system? So historically, we all walked into the post office and the bank and we lodged our money, and your health is your wealth. And we can sometimes want to stick our head in the sands and not look at the debt, but your health should be visible the same way nearly as money. I think health systems are often, there's a lot of similarities with the airline services, but I think actually we've an awful lot maybe to learn on the banking systems. I don't know whether any of the other panel would agree with that, and maybe we should be engaging with them to know how they went from very much a manual to a digitalized system.
Thanks, Cora. And I note there's some pieces in the Q&A also making reference to learning from the airline industry. Adrian, you wish to come in?
Yeah, just well, maybe just in response to what Cora has said, I think it's absolutely correct insofar as if it's service-led,
companies will always respond to what the customer wants. And I think, you know, over the years, when people had more time, they were able to go and see the butcher, the baker, the candlestick maker, and visit all the small shops. Whereas now people want to do one big shop for a month, and then they don't want to see a store between this and then. And again, maybe on the back of COVID, you know, we've all these click and collect services now where, you know, it's all done electronically. And I know there's a lot of resistance in that, and certainly the older age cohort that Morton referenced as well with his dad. You know, I think people of that generation, they much prefer personal service, and that there can be a hesitancy if you're working through an interface rather than a human being. But what ultimately drives it, I believe, is if you get what you want at the end of it, if you get a good service and a good experience online, you'll go back. Do you know what I mean? So that's one part of it. The other thing I just wanted to say, what I originally put the hand up for, was about, you know, I think when we're talking about the integration as well and how we might move forward and, you know, not having all sorts of bits and pieces, I think one key thing that probably hamstrings us a little bit in the health service is the fact that we have public and private, you know, and, you know, there was Sláinte Care, and there was the discussion about the PSC, the public services card and so on. There just seems to be a reluctance on all sides. Certain citizens don't want their information. They don't want to have, you know, one central piece of identification for whatever reason. But I think, you know, again, when you look at COVID, I think I suppose when you talk about rights-based situations, which are already referenced, you know, the fact that the majority, in my opinion, of the population is being held back by a very small number of people who either aren't interested or willing to go in a certain direction, I think, you know, that to me is not democracy anymore. And look, we kind of saw that, and probably maybe a little bit more of a negative side of it in COVID as well, about anti-vaccinations, that, you know, a small part of the population can put the rest of the population at risk, but, you know, where are their rights and their entitlements and so on. So that's not what we're talking about here. You know, we're talking about the possibility of being able to create a system that services everybody's needs, but it has to be hung on one hook. You know, you can't not have a single personal identifier, in my opinion, you know, in 2022, if we're really serious about, you know, giving the best service and integrating the services for citizens. That's something that we should all accept, that's the starting point. And then it's how do you feed your data in there? How do you use it? How do you develop the trust, and so on and so on? That'll be my view on that.
Thanks, Adrian. I'm just conscious of time. I think we've got 2 minutes left, but there was a couple of more questions coming through in the chat. So I'm just going to address maybe one of them, and that's in the whole area of research. I think, Morton, you had talked how the SUNHED is actually a driver of integration, but also probably of innovation. And are there examples of maybe where you've actually, the portal is being used for accessing data for research purposes? Is that done? Is that integrated into it?
It could be, but we have said no, because it's very important that we are not the front door. It's only you and the doctor who have you in treatment who can look up your data. That's very, very important in our agreement with the public. So if there's suddenly is some kind of research, and suddenly maybe some researchers also from US, or some researchers from Africa or Russia, where are my data now? So we have been so precisely saying, no, this is not for research, but you can have exactly the same data if you go to the to ask those scientific boards, can I make research in Denmark? And then we have some ethical boards, and you can ask them, and then you could go in another, you have to use another front door. It is the ethic committees you have to ask, but not us as a front door.
That's really interesting, and we have a quite specific legislation in terms of our GDPR-based legislation here that requires that separate front door, as it were. Sorry, Orla, did you wish to come in?
Yes, I just wanted to make a comment around the consent model. And, Morten referenced it, having the, listening to the users of the system. The citizen jury model is so powerful. It's so powerful because really we, and I could be a member of that jury, anybody here could be a member of that jury in principle. What do we want from the system? What do we want from a portal? What do we want from the HR? What do we want in terms of consent? But perhaps the citizen jury is too small. You could imagine a referendum whereby you ask the people of Ireland what do they want for their health information, and I think that might liberate some of the intransigence around that Adrian's referenced around a minority locking down flexibility to move forward when it comes to consent. But we need to mobilize the citizens' voice directly around health information, because I think ultimately the citizens will be the driver of change in Ireland around this.
Thank you, Orla. And I couldn't wish to end today's discussion
on a better note.
On a better note, to be honest. And I've asked Jen Moran to share the outcomes from our citizen jury in the chat, just in case anybody is not familiar with them. I think certainly if you are ever wondering what the general public actually wants, it's right there on that. And as Orla said, we need this to be built into the very fabric of how we move forward. So it's certainly something that we're looking to do again in IPPOSI, and there's probably going to be an announcement within the next week or so about a second citizens jury, and we look forward to that. And so without any further ado, I would just like to thank all our panelists. I would particularly like to thank Morten for his excellent engagement, and congratulations on all of the excellent work in Denmark. You really are leading the way on that. And I suspect we'll be back in touch with you with a number of follow-ups in the not too distant future. Particular thanks to Adrian, to Orla, to Cora, to Gay, and thanks to the IPPOSI team, Shannon, Jen, and Claire back in the office. And I wish you a happy rest of St. Valentine's Day, and we'll no doubt be in touch with the jury, the outcome of today's discussion, and sign up for IPPOSI sign-up newsletters in the future through our homepage. So thank you, everybody, and have a good rest of your day.
Thanks very much, everybody.
Bye. Thank you.
Pleasure.
Bye-bye.